Respected Professor Sir and respected my Professor Madam and my dear students, on behalf of RAISA, DNB Academic Activities, today I invite you all for another interesting session on pediatric case of tonsillectomy, followed by theory question answer presentation by Dr. Sanjeev Raju from JRH Jajivanram Hospital, Bombay, on fetal well-being monitoring and neonatal resuscitation. I request Professor Sir to allow permission to continue with the class. Sir, can we start the class, sir?
Yes, please go ahead.
Yes, sir. Now I invite Dr. Muttumani and Dr. Sai Dikshit to make the case presentation. Over to Dr. Sai and Dr. Muttumani.
Good evening, sir. Good evening, ma'am.
Good evening.
Shall I start the case, sir?
Yeah, please go ahead.
Sir, a 4-year-old male child by name Vasu, born of non-consanguineous marriage, full-term normal vaginal delivery, coming from Chennai, informant mother reliable, sir. The chief complaints of throat pain and difficulty in swallowing since 10 days, which is progressively increased, and associated with reduced intake of food since 8 days, sir. And history of fever since 2 days, incidence in onset and intermittent in nature, sir. Associated with generalized weakness since 2 days, sir. Patient had history of recurrent episodes of sore throat and ear pain in the past 1 year, which are 3 to 4 episodes per year, sir. And history of ear pain is there, sir. And history of opening mouth during breathing during sleep is present, sir. History of occasional waking during sleep at night due to nose block is present, sir. No history of bad breath, epistaxis, bleeding gums, and antenatal, natal, and postnatal complications are nil, sir. And developed milestones according to age and vaccinated according to age, sir. The history of daytime sleepiness is present, sir. On examination, child is alert, active, and looks dehydrated, sir. Weight 16 kgs and height 94 centimeters, sir. Vitals BP 90-60, sir. Heart rate 120 per minute. Temperature 100 degrees Fahrenheit, sir. Head to toe examination. Bilateral enlarged tonsils grade 2 is present, sir. Bilateral enlarged jugular digastric lymph nodes is present, sir. And had history of adenoid feces is present. Faces is present, sir. Airway, mouth opening more than 2 finger beds. The MPS grade 2. Temporomandibular joint mobile. No loose tooth. Neck movements is normal, sir. Systemic examination, bilateral air entry is present, sir. Severe no murmurs, sir. Summary, a 4-year-old male child with history of repeated throat infections accompanied by ear pain and difficulty in mouth opening during sleep with features of acute and chronic tonsillitis, posture for adenotonsillectomy, sir.
Okay, this is the imaginary case scenario you are presenting, or did you examine any child like this? You are presenting with the case scenario given to you in the by Dr. Kamakshi, or are you presenting it after really examining a baby?
Case given by Kamakshi, sir.
Okay. You are a post-DA or a primary candidate?
Second year, sir, primary, sir.
Primary second year, okay. Have you given anesthesia for a tonsillectomy in your career so far, your training?
In adults, I have given, sir.
You are given for adult, not for a child.
No, sir.
Okay. So in this presentation, you said there is no history suggestive of adenoids. That's what you mentioned, isn't it?
No, sir.
You mentioned there is no history suggestive of adenoids. That's what I heard. If I'm wrong, correct me.
Sir, history of mouth breathing during sleep present, sir.
Okay. So what does it indicate?
Nasal obstruction.
Nasal obstruction. Okay. Anything else? Any other condition, patient will breathe through the mouth instead of the nose. Hmm?
Adenoid enlargement.
Yeah, adenoids only said that's the reason why nasal obstruction, adenoids. Adenoids, where is adenoids? What is the location of adenoid? What is the other name for adenoid?
Pharyngeal tonsil.
Pharyngeal tonsil, is it the adenoids?
It's tonsil itself. It is not
So midline
adenoids.
of the posterior nasopharynx location, sir.
That is called nasopharyngeal
Pharyngeal.
adenoid. The regular adenoids which is found in the oral cavity, what is it called?
Palatine tonsils.
Palatine tonsil. Very good. Okay. Any other tonsil is there anatomically?
So tubal tonsil, lingual
Tubal.
tonsil.
Lingual tonsil. Okay. So there are all of them put together. What is the name for that?
Sir, Waldeyer's tonsillar ring.
Very good. What is the function of that?
Sir, protective role against foreign bodies, sir.
Protective role against foreign body. So supposing a child
Pathogen,
swallows
not
a
body.
coin, will it protect it?
Not foreign body. It is
What tissue it is made up of?
Lymphoid tissue, sir.
Lymphoid tissue. So it will protect against the
Organism.
infections.
Foreign microorganisms.
Infections is supposed to guard which passage it is protecting?
Air and food passage, sir.
It is a aerodigestive protector. It protects both the larynx as well as the esophagus. So it is called an aeroprotective digester. Okay. So now, what are the indications for this any patient to undergo tonsillectomy? How will the ENT surgeons decide that the child will benefit by doing the tonsillectomy?
Absolute and
I'm not asking the indications. I'm asking how to decide whether a child requires tonsillectomy or not. What are the criteria? Now this 4-year-old baby, you said he has come with throat pain, fever, inability to swallow, not able to take food properly. So one attack of this, will you decide that the tonsil should be removed?
So recurrent throat infection, sir.
And the recurrence, how often it should recur? Is there any criteria for that?
So Paradise criteria.
Paradise criteria. What is that?
So greater than or equal to 7 episodes in 1 year, sir.
Very good.
5 episodes in a year for 2 years, sir. 3 episodes in a year for 3 years, sir.
Very good.
And greater than or equal to 2 weeks of lost schooling or work in a year, sir.
Very good. So, is there any history similar to that to decide that the child should undergo adenotonsillectomy now? Did you ask about the past history? How often it got this recurrently, this infection? What is this episode? Is it in the same year or it has happened last year also?
Happened for 3 to 4 episodes in the same year, sir.
Same year. So you have asked all that. You should say that. Okay. Before deciding that if the child requires tonsillectomy, you have to understand, because lymphoid tissue is supposed to be producing. What is the role of lymphoid tissue? How does it protect us from any infection?
it senses antigens in the
Since antigen or antibody? Will it produce antigen or antibody?
it produce antibodies, sir.
Antibodies against the antigen produced by the invading organism. Okay, immunoglobulins and T cells also produced by that. Okay, so it is supposed to be having a normal function, but when itself gets infected, it is like a watchman falling sick. Okay, so you don't want to keep that sick watchman to guard your aerodigestive tract. So that is the reason why you want the tonsil to be removed. Okay, so this criteria should be fulfilled before deciding. Just one episode, you don't decide that the child needs a tonsillectomy, right? Okay. Now, if the child is still sick, will you take it up for tonsillectomy now?
Oh, sir, we have to treat with conservative management, the antibiotics first and for 1 week, and we have
Okay.
to take.
Right. So how long you can wait after you started the child on antibiotic, fever comes down, the throat pain comes down, child starts taking food, child returns to normal activity. So what should be the time interval between an infection and surgery?
2 to 4 weeks, sir.
2 to 4 weeks. Okay, right. What will happen if you do it before that period? Supposing third day fever comes down, child is feeling better and the surgeon is itching to operate. He says, doctor, I want to operate. Can you give anesthesia? Within 3 to 4 days. Now child is perfectly fine, no fever, it is playing. Can you take up the child?
There is a risk of bleeding and
Very good. Then what is the anesthetic immediate risk on the table before the bleeding and other things? Of course, there can be excessive bleeding intraoperatively and postoperatively, agreed. Any other anesthetic implication for that?
airway is more reactive, sir,
Very
because it
good.
leads to bronchospasm
Excellent.
intraoperatively,
Excellent.
Carrying
postoperatively.
the
So it will be a reactive airway. Very good. Excellent. So that is the important, more dangerous acute threat rather than the bleeding. Bleeding, of course, you can always manage with blood and other things, but reactive airway can be problematic, that too in a small child. Okay.
Okay.
Right. Now coming to the indications for tonsillectomy, how will you classify the indications for tonsillectomy?
Absolute indications and relative indications, sir.
Very good. Okay. What are the absolute indications?
The absolute indications are recurrent infections,
Ah,
throat and peritonsillar abscess,
okay.
tonsillitis,
Okay.
the hypertrophy and sleeve suspect of malignancy, sir.
Suspect of malignancy. Okay. This hypertrophy, is there any classification to size, the increase in the size of the tonsil? Do you know of any grading or scoring system for the size of the tonsil?
Grade 0 tonsil absent, sir.
Mm.
Grade 1 tonsil behind the tonsillar pillars.
Mm.
Grade 2 tonsil extend up to half of the distance of the uvula. And the grade 3 tonsils extend up to uvula. Grade 4 is enclosed to midline. It is also called kissing tonsils.
Very good. What is the person's name who described the scoring? Any idea?
No, sir.
It's called Friedman's, Friedmans, Friedman's scoring system. Okay.
Okay, sir.
Any other scoring system you are aware of other than Friedman?
Brodsky scale, sir.
Brodsky scale. Very good. What does Brodsky score say?
Primary.
What is the difference between Friedman and Brodsky scoring?
In Brodsky, we are going to calculate in percentage, sir. How much?
Percentage of occupation of tonsil of the oropharyngeal space. Very good. So what is the importance of this two scoring system? Why should you be aware of this?
So that airway during the intubation.
Airway obstruction and
management.
difficulty in intubation. Excellent, excellent, very good. That is the correct answer for that. So you can anticipate difficulty in intubation or airway obstruction in the child, and that may be, supposing patient gives history of airway obstruction, what are all the other features of preoperatively? How will you assess that child? Supposing there are features of obstructive sleep apnea in a child with a large tonsils.
Okay, sir.
What are all the clinical features you will expect in that child?
So history of snoring, sir.
Snoring, excellent, very good. Then will the child be like an adult complaining of headache in the morning, tiredness? Daytime somnolence already you have said, isn't it?
Sir, inability to thrive, sir.
Stability to cry. But what will you
Inability to
ask?
thrive, sir.
Thrive, okay. I can't heard
Poor
that.
school performances.
Very good, excellent. But what are the things you should ask the parent about this problem of airway obstruction because of the tonsils? enlargement.
Nighttime.
Will the child be waking up in the night with obstruction? Like
Yes.
just like an OSA patient waking up suddenly, jolt,
History
disturbed
of,
sleep. Huh?
history of waking during sleep at night.
Yeah. How many times they wake up?
Yes.
How many times they get disturbed in the sleep? Okay, that is very important history that you should elicit. If the patient gives a history of open mouth, as when you see that, you have to ask all these questions to rule out OSA. It's a very important comorbid condition which may be present. Okay,
Okay.
right. You mentioned about the oral cavity. What else will you examine in the oral cavity of this four-year-old male child?
Dental caries.
Very good. Not only dental caries. What else? Supposing caries is not there, what else will you look for?
Bleeding gums, sir.
Bleeding gums. More than that?
Palate, eye arch palates.
When do the milk teeth fall and the permanent teeth erupt? From what age? Is it from the 4th and 5th year of life?
Yes, yes.
So you must look for any shaky tooth or loose dentures. Okay.
Okay.
So the milk tooth may get dislodged, and what is the danger? If supposing it has got a incisors are shaking, what will you do?
Prior removal, sir.
If it is very shaky, you can remove it before surgery, or else you have to be very careful. Okay.
Okay.
So that you must be watchful whether it is getting knocked out when you do the laryngoscopy and pick it up immediately, so that it doesn't act as a foreign body and get lodged somewhere in the lung and produce a postoperative complication. Okay. So
not only during intubation, also when they put the gags, the mouth gag.
yeah.
Invariably, that's what happens. It comes out
Surgeon
at that time.
also may do that, and you may also do that.
Exactly that age only, sir, 4 to 5.
So that is a very important examination that you have to do in all the pediatric age group. Okay. Is the weight of the child appropriate for the age?
Yes, sir.
You said the child is 16 kg.
Yes,
How will
sir.
you calculate the appropriate age for the weight for the age? What is the formula that you use? Is there any formula you are aware of?
No, sir.
Have you heard of Weech's formula? WEECH Weech's formula. Okay.
No, sir.
You must know whenever you are discussing about pediatric patients, you must know how to calculate or find out the approximate or the expected weight gain. Up to 1 year, there is different formula. Above 1 year, up to 6 years, there is one formula. 6 to 12 years, there is a different formula. Okay.
Okay, sir.
It is commonly asked in the exam, and you have to be aware of that. Right. Okay. Anybody knows that? Who wants to contribute?
3 to 1 year age in months plus 9 by 2. 1 to 6 year it is age in years into 2 plus 8. From up to 12 years it is age in years into 7 minus 5 by 2.
If it's correct, I don't know. I don't remember that, but I read it somewhere. So I can't recall it very fast. Anyway, you have better learn that before you go for your exams. And okay, now with all this clinical presentation, surgeon wants to do an adenotonsillectomy. Okay.
Okay,
So
sir.
the patient is sent to you for pre-op assessment, anesthetic fitness.
Okay, sir.
Will you straight away give fitness for this baby?
Investigations we have to see, sir.
What investigations you want?
Hemoglobin
Okay.
to rule out anemia or polycythemia, sir.
Very good.
Total leukocyte count and differential leukocyte count for presence of infection.
Very good.
BT, CT, PTNF to rule out any coagulation defects.
Okay. Can you find out from the history whether the child is having any possibility of a bleeding disorder?
Bleeding gums, sir.
Bleeding gums. Okay. Then adenotonsillectomy infection, recurrent infections.
Yes, sir.
Any bleeding from the nose can happen?
Mentioned it already in the history. Epistaxis, yeah.
Yes, sir.
You
Yes,
mentioned
sir.
it in the history.
Okay, so that is all these things. Any bruising, often not bleeding, not stopping. Male child, what is the congenital anomaly that can be not exhibited early but can be troublesome during surgery if not properly investigated? Which coagulation abnormality can be very life-threatening?
Hemophilia.
Very good. Excellent. Hemophilia A or B?
Hemophilia.
Hemophilia A. Okay. So male are the persons who suffer and women are the carriers. So female babies, you don't have to worry. But a male child, you have to always ask for any history of bleeding diathesis like joint swelling, sudden effusions, okay, and bleeding occurring even from a small bruise or scratch. That is a very important thing. What other congenital anomalies history you should elicit in a male child coming for a surgery like this? Any musculoskeletal abnormalities possible? Okay, all children, especially male children coming for any procedure like cataract surgery or spin surgery or tonsillectomies, always ask for history of any suggestive of musculoskeletal disorders like Duchenne's muscular dystrophy. Because when the patient is sick, muscular dystrophy may be masked. You may be thinking the child is not active because of the fever and inability to eat and lack of nutrition. But underneath it may be harboring a musculoskeletal problem. So you must ask whether the child has been running about acting or it is always complaining of tiredness, like pain, not mingling with other children, like their peer group. Okay, that is a very important history you should always elicit.
Okay, sir.
Right, you have done all this investigation. Do you want an ECG, echo, X-ray chest, all these things?
Yes, sir. ECG to rule out right ventricular hypertrophy, strains of OSS.
Ventricular hypertrophy. Why ventricular
Right
hypertrophy?
ventricular strains, sir.
Why?
Due to
Sir, chronic hypoxemia because of airway obstruction, sir.
The age is not appropriate for that, no? 4 years.
So it is, do you think it will be so severe like your COPD? It's an upper airway obstruction after all. Do you expect it to be so severe like your lower respiratory tract problem? Okay. Supposing the pulse is irregular when you are examining, will you be worried about this 4-year-old child? You are clinically examining the baby and there is a variation in the pulse, it's not regular. Will you be worried about it or what will you check for? Is it irregularity in a pulse in a child common?
Yes, sir. Common, sir.
What is the physiological cause for that? Respiratory arrhythmias. So child can have up to the age of 10 years, all children can exhibit respiratory arrhythmia. Okay. That is during inspiration, the heart rate will go down. During expiration, it will go up. So that may look like a irregular heartbeat. You need not worry about it. So, but if there is an irregularity, what will you do immediately? Before deciding that it is a respiratory arrhythmia, how to make out that it is only respiratory arrhythmia, nothing serious?
Electrolytes, sir.
Clinically, not electro. Immediately, don't jump to investigations. There are so many things that you can find out by proper examination of any patient. Will you not auscultate the heart?
Yes, sir.
Compare the heart rate with the.
What do you expect to see in the heart?
Any murmurs is pressed.
ASD, VSD. No, all these things can be the cause for the irregularity of the pulse. And that they will not exhibit any much symptoms at that age up to 4 years. Okay. So always auscultate the heart for any ASD or VSD murmur. Okay. So that is a very important clinical examination that you have to do if you find a irregular pulse in the child. Right. You have done the clinical examination and all the investigations have come as normal. There is no leukocytosis. There is no anemia. Bleeding profile is normal. Now the child is posted for adenotonsillectomy after you have given the fitness. So what are all your advice to the mother? Preoperative instructions.
We are counseling to mother and child and admission 2 days prior to surgery.
2
sir.
days prior. Nowadays, most of the major surgeries are done as a daycare procedure. Okay. So you want for a tonsillectomy or adenodectomy admission 2 days prior? Is it you want the nursing home to earn money or is it necessary to admit 2 days prior for a tonsillectomy and adenodectomy?
No need, sir.
No need. It's a daycare procedure nowadays. Okay. Even long
The child.
40 years back itself, it was a daycare. In fact, I have done 1,000 tonsillectomies as a half a daycare procedure. You get admitted at 6 o'clock in the morning, operate and send the child by 12 noon after giving 2 cups of ice creams. Okay. So it is a daycare procedure. But what are all the instructions you should give the parent if you are admitting it only on the day of surgery and doing it as a daycare procedure?
NPO.
NPO. All elective cases you must describe the NPO. Okay. So how long for solid? How long for semi-solid? How long for liquid?
Sir, for clear liquids it is 2 hours, sir.
Okay.
For solid diet it is 8 hours.
6 hours. Okay. So right. So these are all the routine pre-op starvation guidelines you have to follow. Okay. Then any pre-medication required? Will you give? What is your plan of anesthesia?
Sir, general anesthesia.
General anesthesia. Because you can't do this in a local anesthesia, opening the mouth and doing it for half an hour. Okay? It's impossible for a child of 4 years old. So you have to give GA. So if it is GA, would you like to give some pre-medication?
We can give pre-medication, sir, but carefully titrated in patients with the OSA to airway obstructions.
Okay. So supposing if OSA is there, what will you do? If OSA is not there, what will you do? What pre-medication you want to give?
Pedicloral syrup can be given in presence of OSA, sir.
Okay. Any other alternate for pedicloral? Why you prefer pedicloral? What is pedicloral?
Triclofas.
Triclofas. What category of drug it belongs to?
Sedative, sir.
Sedative. Is it a barbiturate or non-barbiturate? Is it a opioid? Is it a benzodiazepine? You have to describe like that what category it belongs to.
Don't know, sir.
What is the dose of this triclofas you will give?
50 mg per kg, sir.
50 mg per kg. How much is the strength of this solution that is available, this syrup?
100 mg per ml, sir.
100 mg per ml.
Yes, sir.
So 16 kg, you have to give 800 milligrams, isn't it?
Yes, sir.
8
ml, sir.
8 ml you will give.
Yes, sir.
Okay. Right. So that is what are the advantages of this? Is there any better pre-medication than this?
Oral midas, sir.
Oral midazolam is available. Very good. So nowadays we have got oral midazolam. What is the dose of oral midazolam?
0.3 mg per kg, sir.
0.3 mg per kg. Okay. How many minutes or hours before?
30 minutes prior to surgery, sir.
30 minutes prior to surgery. Okay. Any anti-silagogue you want to give?
Atropine.
Atropine. You want to give IM or IV?
IV, sir.
IV. So that has to be done on the table, isn't it?
Yes.
So why not prefer to give IM pre-medication? What are the advantages or disadvantages of atropine pre-medication? Is it commonly are we using atropine nowadays regularly?
No, sir.
Why? But all we want to give an anti-sialagogue. What is the drug we prefer nowadays?
Glycopyrrolate, sir.
Glycopyrrolate. Why? Because ester years, atropine was the mainstay for this action, both vagolysis and anti-sialagogue effect. All the ester year anesthetists used to give only atropine. Last 15-20 years, that habit has gone, and we are now using glycopyrrolate only. Why people don't prefer to give atropine, especially for children?
CNS problems, lightheadedness, dizziness kind of thing.
Dizziness, is it only that?
What about temperature?
Oh, okay.
Excessive drying, no, it makes the patient very uncomfortable. Unless you have had one shot of atropine in your life, you won't realize that. It makes your tongue so dry, you want to drink gallons and gallons of water. So if you give it intramuscular to a child and make it get dried up, child will become restless because of that. It will be going on nagging the mother for asking for water. Second, it will make the child very flushed, especially if the child is very unfair like me. The child will look like a red hat. Okay. And the temperature also will shoot up. Many times in those days, if you want to cancel a case, we quietly go and give atropine to the baby and say that baby is running fever, and we used to cancel it. It was one of the tricks we used to play. Okay. So all these things are not wanted. And it produces such a tachycardia as soon as you give it, which is enormous. So that much of vagolysis is not required for the current day drugs we use. So that is the reason why atropine is no more a favored anti-sialagogue or an vagolytic agent. Okay. So oral syrup midazolam or pedicloryl, or we used to use another drug called Finergan. Okay. That is the promethazine. It's the pharmacological name. What are the advantages? It is a wonderful drug. I used to prescribe only that for all my patients, babies. What are the advantages of this promethazine?
Yes.
It has got a sedative effect. It has got an antihistaminic effect. It has got a bronchodilator effect. It has got an antiemetic effect. And it can also reduce the need for opioid drugs or other painkillers. Okay, it can potentiate the action of opioid, so it can reduce the dose. So these are the 5 effects or good effects of the promethazine: anti-sialagogue, antiemetic, antihistaminic, bronchodilator, and potentiation of opioids. Okay.
Okay.
So this is the that's another preferred drug which can be given 0.5 milligram per kg body weight. It is available in 5 milligram in 5 ml syrup form, and you can calculate and give according to the body weight.
Okay, sir.
Right. So, right, you have given the syrup, child is happily sleeping. How will you now proceed to give anesthesia for this child? 4 years old, sleeping on the mother's lap in the waiting area.
Yes, sir.
Surgeon is ready, you are ready. What will you do? Tell me exactly the practical method of anesthetizing this baby. What are all the things that you will discuss with the surgeon here before bringing the child into the OT? Do you have to do some discussion about this surgery?
Sharing the common airway.
Very good. So, how are you going to share the common airway? What question you want to ask the surgeon?
Whether intubate with LMA or
Intubate with the
No, no, no,
LMA?
no.
Which route you want to intubate?
Route of intubation. Route of intubation.
You have to discuss that with the surgeon, okay? Whether you want oral intubation or nasal intubation. When will the surgeon ask for oral intubation? When will he ask for nasal intubation?
If the adenoid is a big one, which might injure and cause bleeding and can cause difficulty in intubation, sir. If it's,
He is not bothered about your difficulty in intubation. Why should he be bothered about it? If adenoids are big, you have to tell him adenoids is big, it may be difficult to intubate. But if adenoids are there, if the surgeon asks for nasal intubation.
no, sir.
Ah. So for an adenotonsillectomy, majority of the good surgeons prefer oral intubation because the nasopharynx will be free and they can use that curette to curette out the adenoids. Okay. On the contrary, if it is a combined, it is only a tonsillectomy and not an adenoidectomy, they can ask for a nasal intubation. Okay. So this point you have to discuss whether you are going to do a combined adenotonsillectomy or you are going to do separate process. Sorry, 1 second. Sir, Sir Rao, sir. No, I will call you afterward. No, I am in the class. I will call you later. Sorry. So that discussion should be done, whether to ask, go for nasal intubation or oral intubation, right?
Okay.
Supposing he accepts for oral intubation, how will you prepare yourself or equip yourself? Will you use the regular Portex tube that is available in your OT for oral intubation, or would you prefer to use some other mode of intubation?
Sir,
Oral ray tube, south pole facing, sir.
Very good. Cuffed or uncuffed?
cuffed, sir.
Cuffed tube will be used for, right. Any other alternate for that?
A normal tube can also be used, which can be fixed in the middle.
Normal tube?
Which can be fixed in the middle.
Normal tube you can fix in the middle. Won't it get kinked when he puts the gag?
Flexometallic.
Flexometallic is the next option. Very good. So either a south pole oral ray tube, cuffed endotracheal tube, or a flexometallic tube, or if you are in the UK, what is the next option? Or you go to UK after your qualification. What do they do there? They use a flexometallic LMA, laryngeal mask airway with a flexometallic extension tube. Okay, that is the next option.
Okay, sir.
Whereas if you are going to do a nasal intubation, what type of tubes you will keep ready?
Ray tube with north pole facing, sir, or
Nasal ray tube or flexometallic again, or have you heard of ivory tube, nasal ray tube? Ivory tube or a nasal a tube which has got a color like ivory, tooth of the elephant. So it is very, very smooth and very flexible without getting kinked. Okay, that also can be used. Right. So that is an important thing you have to decide before bringing the baby into the OT. Okay. For a 16 kg.
Size of the tube, sir.
Size of the tube. So for a 4-year-old child, what size you would like to use? How do you calculate the size of the tube?
Sir, for uncuffed tube, age divided by 4 plus 4, sir. For cuffed tube, age divided by 4 plus 3.5, sir.
Nasal route, this is for oral route.
plus 2 centimeters.
Plus 2 centimeters. Okay, so that is the length of the tube that you have to prepare. I mean the internal diameter, but how do you calculate the length to be inserted?
Age in years divided by 2 plus 12, sir.
12, okay. Centimeters, that is in centimeters. The previous one is in millimeters. Okay.
Yes,
What are the advantages and disadvantages of the ray tube? That is, supposing a surgeon accepts for oral intubation and you put the tube orally, what are the advantages of the ray tube?
You can't suction, sir. Suctioning will be very difficult.
Advantage is first, then disadvantage. Suctioning is difficult.
This kinking won't be there while using that while Davis mouth gag, sir.
Compression, no compression. It's not kinking, it's compression. There will be no compression when they put the gag.
But two disadvantages are there. One is you cannot suction it properly because of the bend. Any other disadvantage?
Airflow
Airflow?
is restricted, sir.
Airflow, why it is restricted?
There will be some air.
Post-op ventilation will be very difficult, sir.
Post-op?
If needed, sir.
No, during the application of the mouth gag, is there any problem with the ray tube? Because of the fixed curvature and fixed length. Supposing you mistakenly take a 5-size tube because you'll find the glottis big enough and you push it in. Okay? And when the surgeon applies the oral gag, mouth gag, can there be any migration of the tube?
Yes, sir.
Yeah, it can go inside to bronchus. Okay? So you have to carefully auscultate. Once the mouth gag is applied, you must always auscultate for the equal air entry on both sides of the chest. So for that, what monitoring you will require?
ETCO.
ETCO2. Very simple. Supposing ETCO2 is not there, you are doing it in a small nursing home. There is no ETCO2.
After fixing, we have to auscultate both sides.
Precordial stethoscope.
Precordial stethoscope.
Precordial stethoscope. Where will you fix it?
Apex,
sir.
Apex, sir.
Apex of the heart. Is it the correct place to fix it for a child if you want to find endobronchial intubation?
Where the
Best will be to place it over the manubrium sterni,
management.
not at the apex, so that you can find out whether the tube is migrating to right or left. Okay. And what are the, apart from monitoring the respiratory sound, what other advantage is there in having a precordial stethoscope? Is it helpful only to is it helpful only to find out the equalness of the air entry, or is it useful for some other monitoring also?
Heartbeat regularity.
Heartbeat?
Regularity.
Regularity, of course. Regularity, you can palpate the pulse itself and find out. Especially small babies. It can tell you about the volume status, the contractility of the heart, because children are rate dependent for their cardiac output. So you can find out the sound of the heart contraction, the first and second sounds. It will be loud and strong when there is adequate volume. But when they become hypovolemic, it becomes muffled and soft. So by the change in the heart sounds, beating sound, you can find out the status of the hydration, whether the child is adequately hydrated or has become hypovolemic. That is another important monitoring that can be done by placing a precordial stethoscope in pediatric patients. Okay. So, right now you have decided about the circuit, the tube, and the general anesthesia has been planned. So what circuit you want for a 16 kg child?
Pediatric circuits.
Jackson-Rees modification of ISTPs. That is a full answer for that. Jackson-Rees is only a part of the answer. So Jackson-Rees modification of ISTPs, otherwise called Mapleson Mapleson F. Okay. So what is the advantage of using this Mapleson circuit, Mapleson F, or Jackson-Rees modification of ISTPs for a small child?
Reducing the dead space, sir.
Reducing the what dead space? Apparatus or physiological, anatomical? Which dead space gets reduced?
Apparatus.
Apparatus dead space is low. Okay. Then
Can be used for both spontaneous and controlled ventilations.
very good. It has got no valve, so least resistance. That is the first answer that should be told in the examination. Because there are no valves in the circuit, it is the ideal circuit for spontaneous respiration in babies. that will lead to the question, what type of anesthesia, I mean, the ventilation you are planning. Are you going to control the ventilation, or are you going to allow the child to breathe spontaneously after induction?
Control the ventilation, sir.
Huh?
Going to control the ventilation.
You want to control the ventilation. Is that how you have been taught? All the students, are you all taught only to do the control ventilation?
Yes, sir.
Okay. Nowadays, it is all spontaneous. So we never used to, even now, if I am called for a tonsillectomy case, I won't do the control ventilation. Because it's such a short procedure, you don't want to use polypharmacy in a small baby. So I would go for a depolarizing and muscle relaxant, intubate the baby, and once the baby recovers spontaneous respiration, I will maintain the spontaneous respiration with the oxygen, nitrous oxide, and a volatile,
Okay, sir.
and recover the child at the end of the procedure. Extubate once the reflexes are strong enough. Okay, but whatever technique you have been trained, there is no harm in saying that. So, right. So if you plan to do control ventilation, what are all the drugs you are going to use? How are you? Tell me exactly the steps how you will anesthetize this baby. The baby has been brought in. It is nicely sleeping with the oral premedication that you have given.
Yes, sir.
Now, once it is brought inside the theater, the child is likely to wake up and cry,
Yes, sir.
not seeing the mother. So how are you going to manage for this?
So first I will connect it to monitor, sir. Then put the access.
Without waking up the child, can you connect all the monitors? Put the pulse oximeter, put the ECG leads,
Yes, sir.
put the BP cuff. Will the child be so asleep when you do all these things in a new environment?
Yes, sir.
What is the technique of bringing a quiet child inside the OT? How will you?
Steel induction.
Huh?
Steel induction technique, sir.
Steel induction technique. And what is steel induction technique? How will you do that?
So shifting the baby while
Hmm.
fallen asleep from parents itself.
No, that's what I'm saying. Majority of the children will be happily sleeping in the mother's lap. Once your theater assistant goes to pick up the baby, it will wake up and look around and then start crying because it's the age 4 years. You know, the separation anxiety
Separation
will be
anxiety.
very high, isn't it?
Yes, sir.
So
Subanesthetic dose of ketamine.
subanesthetic dose of ketamine intramuscular can be given,
Yes, sir.
even though the child is going to cry with the painful injection,
Yes, sir.
or any other method. Hmm?
Yes, sevoflurane induction.
Induction, yes, inhalation induction with the attendant following the baby,
Yes, sir.
which is not practiced commonly in our setup, but it is a common practice in the Western countries. They have a separate induction room. So they bring the mother along with or the attendant along with the child, and then make the baby inhale through a toy or some deceptive induction is done by making the child hug a teddy bear or something, and the people try to pass the gases through that, and then make the child unconscious and then shift it inside the OT. Okay, all that is not available here, so we can go for subanesthetic dose of ketamine, or we can start doing inhalation induction in the presence of the attendant to some extent, and then bring the baby to the OT. Okay,
Yes.
right. You want an IV line or you don't want an IV line?
It's a good IV access I needed.
You need a good IV access. How will you secure a good IV access without making the child cry?
So by applying Emla cream, sir, eutactic mixture
Eutectic mixture of Emla cream.
Lidocaine 2.5%.
What is the technique of applying that? How far before the venipuncture you should apply that?
So 30 minutes before.
30 minutes is too short a time. At least 1 hour, 60 minutes is necessary. And then what else you should do? Just like that, you just apply like Odomas and leave it?
Cover with the sheet, sir. I mean,
Cover it with a sheet. What sheet?
plastic adhesive.
Compressive sheet should be applied on that.
Compressor sheet. What is the name for that? It's not called compressor sheet. It is called transparent adhesive dressing, offsite.
Offsite.
Which you apply for your venipuncture catheter to see whether there is any bulge or any dislodgement. Isn't it? Transparent dressing. That's called transparent occlusive dressing should be applied over the ointment. Okay? Proper terminology should be used to get the maximum marks. If you say compression and all that, the basic technique is right, but the proper terminology is not used. Okay, right. Okay, and at least 1 hour before you should apply it over the selected area where a nice vein is available, and you can even do it in the waiting area itself. The baby is cooperative. If you have gained a good rapport with the child, you can show him a 5-star and then do this without making the child cry. Right. So you have secured an IV line. What fluid you want to give? And how much fluid you want to give for this surgery?
Sir, isotonic crystallites like ringer lactate solution fluid, sir.
20 days.
Is the ringer lactate really isotonic? What is the
Slightly hypotonic, sir.
Slightly hypotonic. But for all practical purposes, we take it as isotonic. Okay. So how many ml per kg you will give?
So I will go with holiday cigar formula, sir.
Holiday cigar formula.
The maintenance fluid.
Okay.
First 10 kg 4 ml per kg per hour, sir.
Okay.
Next 10 kgs 2 ml per kg per hour. For further kgs 1 ml per kg per hour.
Okay. Now you have said this baby is 16 kg. So how will you calculate and keep it ready?
46.
52, sir. 52 ml per kg.
52.
52 ml per hour, sir.
Okay. So 52 ml, how will you deliver correctly? What type of IV set you require for that?
Pediatric burette.
Pediatric burette.
Burette set, sir.
You have to use a burette set so that you don't overhydrate the child. Okay. So all children, better to use a less than 20 kg, better to use a burette set so that you don't overhydrate the kids. Right. Right. All these things, IV line is ready. Circuit is ready. Tubes are ready. Laryngoscope is ready. What other things you will check before you bring the child inside? What is the one I have not told? The checklist.
Yeah, sir.
First and foremost, it should have been told.
Pre-op temperature control.
You are going to give GA, you are going to put a tube, you are going to do a scopy.
Suction.
My God, that is the first thing you should always answer. Any GA, first and foremost thing to be checked is the suction. Okay, how will you check the efficacy of the suction?
By putting the finger at the level of the chest, sir, we have to.
Putting the finger at the level of chest. Whose finger at whose chest? Connect the suction tube to your thumb. Okay? And then leave your hand. And it should get stuck to the thumb. It should not fall off. That is the simplest method. And if it gets stuck without falling off, what is that amount of, what is the negative pressure that is available there?
Minus 25 too.
25. Minus 25, you think you will get stuck there? Tomorrow when you go to your OT, if you have a meter or the gauge to assess the negative pressure that is created, you could just keep 25 and try to keep it. See whether it is sticking or whether it is falling off immediately. It requires minimum 250 to 300 negative pressure, millimeters of mercury. Okay, so that is a normal negative pressure that will be created to have adequate suction. Right? So suction should be checked and a good various size catheters should be available for suctioning. Right. Now how are you going to induce anesthesia? Tell me all the steps. Child has been brought inside the theater, monitors applied, the IV fluid connected. all drugs loaded and ready. What is going to be your induction agent of choice?
Sevoflurane.
Inhalation, like injection.
Inhalation is IV line is available. Why you want sevoflurane now?
Propofol I'll choose.
Propofol. Okay, propofol can be given. Then what
So
about
fentanyl is short-acting opioid, sir.
short-acting opioid? How painful is tonsillectomy? Is it very painful or
Yes,
not?
sir.
Very
Very painful, sir.
painful. So how long the pain can last?
Up to post-operative 3 to 4 days, sir.
3 to 4 days. Very good. So how are you going to manage the pain intraoperatively and postoperatively?
So I will go with injection paracetamol IV, sir.
Paracetamol IV for a small
15 to
child?
20 mg per kg, sir.
Yeah. Don't you like to have a suppository which can be
Yes, sir.
slow and effective rather than an IV?
Yes, sir.
Yeah. So suppository, how much milligram you can keep? What is
30 mg per kg, sir.
30 mg per kg. Yeah, right.
Sir, we'll ask surgeon to local infiltration of tonsillar fossa, sir.
That is at the end of the surgery, but during intraoperative period. Okay, now you have given, you want to give the analgesic before the induction agent or after the induction agents?
Before induction agents.
What do you call that? If you give analgesic
Preemptive
before
analgesia.
preemptive
Empty
analgesia.
analysis.
Very good. So you have given all these drugs, you have given the induction agent. How are you going to paralyze the child for intubation?
This is a non-depolarizing muscle relaxant.
Okay, you are planning for controlled ventilation, so
Yes.
you can give a non-depolarizing muscle relaxant. Which non-depolarizing muscle relaxant you will prefer?
Acronium, sir.
Acronium. Okay. Acronium, is it intermediate acting or short acting or long acting?
Long acting.
Long acting. So you want
You
the
prefer
longest.
atacurium or suspectacurium instead of lecuronium? Why are you choosing lecuronium?
How long your surgeon is going to take for a tonsillectomy? Have you seen surgeons operating for hours together for tonsils and adenoids?
No, sir.
Usually it is a very short procedure, isn't it?
Yes,
A good
sir.
surgeon will finish it off in 15 to 20 minutes time. Okay? So better to use a short acting non-depolarizer rather than an intermediate or a long acting drug. And then you have to be waiting for the attempts to return. And surgeon, if he is a busy surgeon, he will say, I would have finished 3 cases by the time you recover the first baby. Okay? Right. Okay. So your plan is, supposing you plan to leave the baby on spontaneous, what will be the choice of your relaxant?
Depolarizing muscle relaxant.
Like
Succinylcholine.
succinylcholine. Otherwise,
Pro-
only you can use the succinylcholine, or is there any very short acting non-depolarizer also is available?
Procronium, sir.
Procronium is not that short acting.
Mivacurium, sir.
Mivacurium is available. Yes. Mivacurium is equal to hexamethonium, such a short acting drug, not more than 15 minutes at the max. So mivacurium also can be used as an intubating agent. Right. How are you going to maintain the anesthesia?
With oxygen, nitrous
Air,
oxide and
air or
CO2.
nitrous oxide or
Oxygen and nitrous oxide.
nitrous oxide. What is the risk of using nitrous oxide?
Absorption atelectasis.
Absorption atelectasis with the nitrous oxide.
O2.
Diffusion hypoxia.
Diffusion hypoxia towards the end. More than that, a surgery in the oral cavity, nitrous oxide usage,
Closed cavities.
post-operative nausea and vomiting.
Vomiting.
Always it's more with nitrous oxide. Whether it is oral surgery or abdominal surgery, any surgery, PONV is very, very common with nitrous oxide.
Yes, sir.
So that is the reason why we prefer not to use nitrous oxide nowadays, right? So the volatile inhalation agent of choice is
Sevoflurane, sir.
Sevoflurane, isoflurane, desflurane, whatever you have, you can use. Right? Okay. So, what stages of surgery you should be very careful? Tonsillar adenoidectomy.
Sir, mouth gag application.
Very good. So during the mouth gag application, what precautions you have to take? You must make sure that the baby is fully relaxed or partially relaxed.
Fully relaxed, sir.
Should have adequate relaxation to open the mouth adequately. What is the position that is adopted for tonsillectomy?
Rose position.
It's called rose position. How do you mostly the anesthetist only will position the patient for most of the head and neck surgeries. Surgeon, because he will be well washed and draped, he won't be in a position to do that. So it is always the anesthetist who does the positioning for the surgeon. So how will you position the baby?
Sir, extending the neck.
Extend the neck by what? How do you do that? You should know.
Placing a pillow or sandbag under the shoulder, sir.
Shoulders, and then extend the neck. During extension, what precaution you should take?
Sir, tube migration.
Tube migration is there, and doing hyperex. What is Greisler's syndrome?
Compression of the cervical spine.
Which cervical? Entire cervical spine?
Atlantoaxial,
correct. So during that extension at the atlantoaxial joint, it can cause the rupture of the ligament. Okay, especially if the child has got a Down syndrome, you have to be very, very careful. That's called Greisler's syndrome, and it is non-traumatic dislocation or compression of the atlantoaxial joint. Okay, that can produce later on severe neck pain or even neurological damages. Right. So Ross position to be adopted. Then the surgeon applies the mouth gag. Then what are all the techniques of excising the tonsil?
Sir, cold surgical techniques, hot surgical techniques, sir.
Very good.
In hot surgical techniques, ultrasonic dissection, radio frequency ablation, laser method.
Very good.
Electrocautery method, sir.
Excellent. Okay.
In cold surgical technique, it is blunt dissection and tonsillar snare methods.
Very good. So what are the advantages and disadvantages of each of this technique?
So in cold surgical technique, there will be increased risk of bleeding and there will be more post-operative pain, sir.
No. Pain is less in cold technique. Pain is more only in electrocautery technique, but bleeding is less. Okay. The cold technique is always older technique. So they catch. What is the blood supply of tonsil?
Sir, facial artery, lingual artery, maxillary artery, ascending pharyngeal artery, sir. In facial artery,
does it give directly to the tonsil? What is the name
tonsillar
of the
artery,
branch? Tonsillar branch of facial artery.
Tonsillar branch of facial artery, sir. And tonsillar branch of ascending
lingual artery, tonsillar branch of ascending
lingual branch of lingual
all
artery.
are called tonsillar branches. Okay, tonsillar branches from the ascending pharyngeal, ascending palatine, facial, and lingular branches, supplying which does it supply entirely or from the poles?
Sir, entirely, sir.
Entirely entering through the poles, upper pole and lower pole. Okay, and then they intermingle and then interdigitate. So the entry point is at the pole. Okay.
Okay, sir.
So what is the cause of post-tonsillectomy bleeding? Is it an arterial bleeding or a venous bleeding?
External palatine vein.
External palatine vein, which pierces from the posterior palatine. That is the most common reason for the bleeding that can happen. Very good. So these are the techniques of removing the tonsil. So at the end of the procedure, when the surgeon says, I have completed, what precautions you will take before recovering the child?
Sir, antiemetics I will give, sir.
Very good. What are all the antiemetics you have to give?
Ondansetron 0.1 mg per kg, sir. Then dexamethasone 0.1 to 0.2 mg per kg. Otherwise, I use combination of both, sir.
Very good. Is there any other advantage in giving dexamethasone other than the
It will
antiemetic
reduce
effect?
airway inflammations.
Causes also reduce pain. Pain also
Yes.
conceived is supposed to be rest. So many people nowadays routinely use dexamethasone along
Yes,
with the ondansetron. But what are all the other precautions you will take before recovering and extubating the child?
Thorough oral suctioning to remove the
Okay,
Bleed.
It should be in slight lower position, sir.
okay,
With lateral, head should be slight lower with the lateral position, sir.
okay. What mistake the surgeon can do which you can rectify?
Do you want to inspect the oral cavity?
Throat pack may be
Different
kept
things.
inside.
Throat pack or cotton balls used by the surgeon, especially during the dissection of the upper pole. Majority of the surgeons remove the upper pole and then stuff that cotton ball into the between the anterior and posterior pillars, okay? And they forget about it. Post-op, it will slowly migrate, and I have seen cases getting obstructed, and you have to emergency remove that with the Michael's forceps. All those complications can happen. So always be watchful when the surgeon uses those cotton balls to cause hemostasis, and make sure that the nurse counts the number of balls she has taken before giving it to the surgeon. And just like counting the pad count after abdominal surgery, you must make a count of the number of cotton balls that were used. So 15 balls she has taken, all the 15 should be accounted for. Then only you should allow the surgeon to go out.
Okay, sir.
So you must also inspect and remove all those packs and gauze pieces. Other things should be entirely removed. What is Coroner's clot? Coroner's clot. Plot.
Presence of clot in the posterior nasal barrier.
Especially after adenoidectomy, no, there may be a big blood clot in the nasopharynx. So always make pass the catheter gently and make sure that it goes in freely before you extubate the child. Otherwise, it can migrate from the posterior nasal cavity into the oral cavity and cause an obstruction.
Airway obstruction. Yes, sir.
So that is a very important thing, inspection, that you should make sure. Right. What is the position of the baby to be adopted after extubation?
head down position.
Fowler's
left
position, sir.
Head down, lateral,
Fowler's position.
Fowler's position. Hmm.
Head down, sir, because to prevent aspiration, sir, of any
Only head down, supine head down, or lateral head down, or prone head
left
down?
lateral head down, sir.
With any one leg flexed and
More than head down, turning is very important. The child semi-prone with a pillow under the lower abdomen and the knees, okay, and with the head
Recovery
down.
position.
So that is the position to drain the secretions. Or so how will you know that there is a small ooze or bleeding post-operatively? What are the clinical symptoms of
history of frequent swallowing, sir.
Swallowing.
Elicited from the mother. And there will be any history of emesis of coffee brown vomiters.
Very good. So there may be bleeding, obvious bleeding from the nose and mouth also whenever the child cries.
Yes, sir.
So,
Unexplained tachycardia.
so what are the various categories of bleeding that can happen after tonsillectomy?
So primary hemorrhage, reactionary hemorrhage, secondary hemorrhage, sir.
Very good. Okay.
Primary hemorrhage which happens during surgical time.
Excellent.
Reactionary hemorrhage which occurs within 24 hours of surgery.
Very good.
Due to displacement of blood clots,
Or
slippage of ligation bleeding vessels.
very good. Okay.
Then
Right. Reactionary can happen later on because of mainly infection up to 28 days after surgery. Okay. Secondary hemorrhage. That is the secondary.
because of infections.
Okay. Supposing after 4 hours you get a call from the ward.
Yes, sir.
The child has been having bleeding right from the time it has been brought to the post-anesthetic care unit. And the nurse gives you an SOS call to come and see the JB.
Yes, sir.
Go find the baby who is crying, who is having bleeding from the nose as well as the mouth, restless, and you suspect post-tonsillectomy bleed.
Yes, sir.
What will you do? What will you do? It's a common theory question scenario also. How to manage post-tonsillectomy bleeding.
So we'll plan for first I will assess the vitals, sir.
First examine the baby. Okay. So what are the challenges in management of a post-tonsillectomy bleeding?
Sir, child should be considered as full stomach, sir, because of swallowing of blood.
Very good. Excellent.
Then there will be anticipated difficult airway management
Very
because
good.
of previous instrumentation and airway edema.
Okay, very good, accepted. But what is the first and foremost concern?
Fluid resuscitation should be done because
Fluid
of
resuscitation.
blood loss, sir. Fluid resuscitation, sir.
Very difficult to assess the blood loss. Why
Yes, sir.
very difficult to assess the blood loss?
It will be swallowed.
Half the blood is swallowed.
Half the blood is swallowed, half is coming out. So very difficult to assess what is the exact amount of blood that has been lost. So how to find out from the clinical signs that how much blood would have been lost? How do you categorize hemorrhage? What are all the classes of hemorrhage?
Based on tachycardia.
Based on tachycardia or volume? Classification of hemorrhage is
Means of
class 1, class
dehydration,
2, class 3, class 4. That's what I have read. So from 500 ml to say 500,000, 1,500, more than 1,500. These are all the 4 categories that I have been taught. So supposing in class 1 hemorrhage, where you have lost up to 500 ml, what will be the change in the cardiovascular, respiratory, CNS?
Normal. Class 1, everything will be normal. Sir.
Adult will not have any problem at all. Okay. Class 2, what will be the first change you will find out?
Heart rate will be more than 100.
Heart rate may not go up. Diastolic blood pressure will go up because of the peripheral vasoconstriction. Class 3, you get tachycardia. Okay. Class 4 is very severe. Pale, ashen, cold peripheries, periphery pulse, not recordable BP, all these things will happen. So based on this knowledge, you have to examine the child and find out how much of blood loss would have occurred roughly. Right. Supposing what is the simplest test you can do to find out the hypovolemia in a baby? Capillary refill time. Excellent. Okay. So must be less than, what is the normal value?
So 3 seconds, sir.
2 seconds, less than 2 seconds. If beyond 4 seconds, so consider as very significant blood loss. Okay. Right. Supposing you find the capillary refill is 4 seconds and pulse is about 140 and BP is about 60 by 80 by 60. What will you do?
20
You
ml per
plan
kg.
transfusion.
We'll give a 20 ml per kg
Sir,
bolus
we'll
of
transfuse blood if it is available readily.
Do we normally do a grouping and cross matching for tonsillectomies?
Yes, sir.
Yes, sir. Nowadays it is not common. Okay. So we just know the group, but we don't reserve blood or anything. Just do the grouping and grouping alone is sufficient. Even cross matching is not done or reservations are not usually done. But so first find out whether appropriate compatible blood is available. Then start resuscitating with fluid and then alert the theater to shift the child. Okay. Only after you are satisfied with the hemodynamic stability, you should shift the baby to the OT. Okay.
Yes.
What other preoperative, preparation you should do before you shift the baby?
Pre-medication should be avoided, sir.
I'm not asking what you should not do, but I'm asking what you should do. One is to alert the blood bank for a supply of blood. Any other thing to be done in the ward itself?
Latent IV cannula should be set.
IV is already there. Nice, good IV cannula is flowing. And you have started.
Lateral position to be maintained, sir.
Lateral
position to be maintained to prevent the.
We said it is difficult to find out the blood loss because of the swallowing of blood. So should anything be done about that?
Can we put a NG tube?
Yes, sir.
You can put a tube orally, okay, and aspirate as much as possible before shifting to the OT. Okay, so that is the. Will you keep that tube, nasogastric tube or orogastric tube during induction?
Yes, sir. It is
After induction.
first.
You have to remove in any
What?
patient who has got an NG tube for deflating or decompressing the stomach. It should be removed during induction and intubation. Otherwise, the cricopharynx will be open. Okay, so any accumulated fluid can regurgitate.
Okay,
So
sir.
you should resort to the normal cricopharyngeal action. So you must remove a NG tube or orogastric tube before you do the induction in any patient, whether it is an adult or baby like this, or whatever condition you have passed an NG tube, it is better to. A very common mistake done during intestinal obstruction surgeries, emergency. You put what they put the NG tube for deflating the stomach, and you induce with the same NG tube in position, you will end up with the problem of aspiration. Okay, so you have to remove all the tube. You can again introduce it again after induction, after you secure the airway. So two things that you have to remember is adequate resuscitation, preservation of blood, then pass an orogastric tube, remove all the swallowed blood as much as possible, and then stabilize the baby and shift it to the OT. Okay. Now comes the second challenge: how to anesthetize this baby. Baby may be restless, crying because of this irritability, because of the blood loss and the frequent irritation of the blood from the nose and throat. So child may be quite restless. So how are you going to manage this baby?
So rapid sequence induction, sir, with depolarization.
Options are always inhalation and intravenous
Yes.
induction.
Yes.
Okay. Intravenous is much more easier and smoother because you can rapidly make the patient unconscious.
Yes, sir.
So because the IV line is already available, you can go for intravenous induction. So what is the best induction agent? You are planning to do a RSI also, rapid sequence induction. So what are all the steps in RSI for this case?
Sir, I will use thiopenton as induction agent.
Thiopenton, okay. Already baby is having a BP of 80/60 and you have somehow resuscitated. Would you like to again vasodilate the baby and cause again a fall in BP?
Ketoform.
You can think of a combination of ketamine and propofol. Ketofol, which will be having a safe maintenance of the cardiovascular stability at the same time as smooth induction. Okay? So that will be a better choice. Then quickly, rapidly paralyze the child with dexamethasone and then try to intubate the baby orally. Never do nasal intubation in a bleeding tonsil. Always do a oral, especially after adenoidectomy. You should not re-intubate through the nose. So do a oral intubation and then try to manage the. So mostly it will be a venous ooze which can be tackled easily. Sometimes rarely any not slipping arterial bleed also can be there. So it has to be properly controlled and recovered.
Okay.
Nowadays they do laser tonsillectomies, isn't it? Some of the surgeons are fond of doing laser tonsillectomies. So what are the precautions you have to take if it is a laser tonsillectomy?
Microdilated tube.
Special tubes have to be used. Not only special tube, laser theater should be specially designed for that. And it should have all the adequate signals outside saying that once the laser procedure starts, unnecessary movement inside out should not be there. All trained personnel should be there. Protective gear should be there for all the surgeons and other assisting people to avoid laser damage to the eyes or facial structures. And you must always be alert to prevent airway burns.
Fire.
The chances of airway fire is very high, so you must be very alert about it. And if it all happens, immediately cut off all the oxygen and flush the area with saline, extubate the kid, and then
Blood.
stop the bleeding and then re-intubate later. Okay, these are all the steps that you have to know that. Kamachi, can I share the screen? Kamachi, is he there? Are you all able to see the screen?
Yes, sir.
Okay. So this is a small PPT. Whatever points you have told me, I just got it in the form of a PPT. So most of the points you have told. This is how a tonsillar infection looks like. What type of tonsillitis is this? You find lot of white specks here, here, and all that. So what are the
Tonsillar abscess, sir. Paratonsillar abscess.
yeah, paratonsillar abscess na in the areas will be
Follicular
swollen.
Tonsillar
tonsillitis.
lith
Is it-
chronic.
Who said follicular tonsillitis?
Muttumani.
Follicular tonsillitis, Muttumani is correct. 100%, 100 marks for that. Muttumani is correct. There are three types of tonsillitis: follicular, membranous, and catarrhal. Okay, so
Yes.
this is a follicular type of tonsillitis. Sometimes you may find a patient who is not having any pain or fever or symptoms of tonsillitis, but this sort of white specks may be there in the tonsil. Do you know what is that called?
Tonsillar lith.
Tonsillar lith is a big stone-like thing. There may be small multiple white spots like this. That's called keratosis of the tonsil. It is a non-infective condition, keratosis. It may be a white spot, but this is actually the classical follicular tonsillitis. So for doing tonsillectomy, what are the indications? You have already mentioned the absolute indication. One of the important absolute indication is obstructive symptoms, obstructive sleep apnea, or recurrent peritonsillar abscess, or febrile seizures. If the child gets recurrent seizures because of fever, because of tonsillitis, that is one of the reasons for tonsillectomy. Whereas relative indications, recurrent tonsillitis, 7 episodes in 1 year, or 4 episodes in 2 years, or 3 episodes in 3 years, like that you can grade and then decide. It's bad breath, tonsillitis, or dental and orofacial abnormalities. Some children, they develop buck teeth because of the adenoids and tonsils infection, and diphtheria, and possibility of getting rheumatic fever is very high. So all that you have to do. But contraindications are bleeding disorders, bilopharyngeal insufficiency, and if there is a cleft palate or submucous palate, you should not do tonsillectomy. Acute infections and uncontrolled systemic disease, anemia, and extremes of age. And then there are indications apart from the tonsillar problem for tonsillectomy. One is elongated styloid process. This is called Eagle syndrome, where the patient may have nagging throat pain constantly, but the tonsils may appear quite normal, and it is a palpatory finding through the tonsillar fossa confirmed by palpation, and you have to do a breakage of the styloid process. Okay, so the surgeon will remove all the attachment of the styloid process through the tonsillar bed itself, and then break it at the origin and remove it. That will relieve the pain. And glossopharyngeal neuralgia is another condition. And during uvuloparyngoplasties, you have to do this tonsillectomy, which are all not because of infection or other reasons. Then the procedure is usually done under general anesthesia, and the position that you have to adopt is rose position. And the techniques are dissection and staring. You can use diathermy, you can use coablation, ultrasonic dissection, laser. These are all various methods of doing it. And this classification is Friedman's grading based on the size and how they are coming. And the class 4 is the kissing tonsils, where both the tonsils look or come to midline each other. Then the Brodsky scoring is the one where the tonsils compared to the area occupied into the oropharynx. So when it occupies more than 75% of the tonsils, I mean oropharynx, it is called degree of 4. And coming to the types of tubes, preformed oral tube for conditions where you want to do adenoid and tonsil removal. And always the first adenoid should be removed so that any bleeding can stop before you complete the surgery. Okay, so normally experienced surgeon will first remove the adenoids, pack that, and then proceed with tonsillectomy by the time the adenoid bleeding, because it's a blind procedure. You have to just scoop it out and then pack that area. So adenoidectomy should precede the tonsillectomy. And this is the oral intubation with a nasal nasal intubation with a nasal ray tube. And this tube is the one which I told you about, the ivory tube. The color is totally different. Here it is transparent. It is not transparent. It is looking shiny like the nasal or North Pole ray tube also can be used if supposing the surgeon wants a full whole oral airway, oral cavity for himself. This is the flexometallic ray tube, LMA, which can be used, and this is how it is placed. No, you have to make sure that there is no compression of the tube or the cuff. So, but this produces a good free area for the surgeon, and there is no postoperative bucking or coughing, and surgeon in this, the recovery will be much more smooth than the endotracheal intubation in these cases. And I found one PPT by Dr. Tushar Chokshi from Ahmedabad, and he has given the title 1.5 magic for this entire procedure. And he says he uses atropine IM 15 minutes before on or 1.5 minutes before IV, which is not done. So I just wanted to show these slides that these practices, he has published this PPT in 2015, and he claims that he has done more than 1,000 tonsillectomies using this technique. I just want to emphasize that please don't use atropine as a pre-medication, either IM or IV. And pre-induction, he says he gives ondansetron, diclofenac, and because they want to avoid giving any narcotics or opioid, because most of them nowadays are sent as take care within 4 to 6 hours after surgery. And so diclofenac sodium 1.5 milligram and the antibiotic, all of them are given as pre-induction drugs. And these are all the monitors that are used, like pulse oximeter, end-tidal carbon dioxide, precordial stethoscope, and ECG, temperature monitoring. I think this is all little too much, and automated blood pressure is the must. And his technique of induction is ketamine 1.5 milligram per kg plus propofol 1.5. This is the combination which we call it as ketofol, or thiopentone sodium 4.5, slowly IV, and then followed by succinylcholine 1.5 milligram IV for paralysis and intubation. And then this is the technique he says he uses for maintenance, where he uses 1.5 liters of or 3 liters depending upon the adult or pediatric case, oxygen nitrous oxide, respiratory rate 15, tidal volume 7.5 ml, with maintenance of relaxation by giving succinylcholine repeatedly every 3 minutes to 5 minutes. This is a very bad, dangerous practice, because repeated use of succinylcholine in pediatric patients can produce bradycardia, number one. Number two, it is quite arrhythmogenic. Number three, it can convert itself into phase 2 block, which you will find it difficult to get out of it. So this was a very old time technique, which I don't know, he has carried on for almost 1,000 cases, and he claims he has not had any complications at all. But just for the sake of advice to not to use this technique, I am telling it. So you can give Saxa and intubate, and then once the spontaneous comes on, you can just allow the baby to breathe throughout the procedure and cut it off and recover the child. or plan for a control ventilation and do it from the beginning. So this repeat schooling should be totally avoided, and he has published it also in the net. So I just wanted to caution you all about that. And these are all the methods of dissection, how they do it. For the benefit of those who have still not seen a tonsillectomy, this is the Boyle-Davis gag, mouth gag, which is inserted and opened and held in position with a what is called the Draffin's bipod stand. You will have some holes there. I am going to show the picture of that. Then you just dissect it holding with the Valsalem forceps, pull it out, and then start incising and removing. All those are surgery steps. And post-operatively, patient is better nursed in the lateral position. So more than the head down, you have to first say about the lateral position. I heard somebody saying head down repeatedly, but more than head down, lateral is very important. And kept nil orally until full recovery and conscious levels are there. Watch for the bleeding. And earliest sign will be frequent swallowing. And usually they serve the babies with ice cold fluids or ice cream to that the ice will cause constriction. So it will help in hemostasis also. And of course, babies will love to eat something cold and sweet. So that habit is continuing. The complications are hemorrhage, different type. We have seen primary, reactionary, and secondary. And other complications can be, you can sometimes open the mouth too much and then find it difficult to close it. Temporomandibular joint dislocation can happen, especially if the surgeon, some of them, very rough, open the blade very forcefully. Then it can result in a TM joint dislocation, or it can cause injury to the lips or mouth commissures. You open the mouth too wide, the angle of the mouth may get cracked, or injury to tongue, uvula, and soft palate, and rarely glossopharyngeal nerve or pharyngeal venous plexus, carotid sheath. You have to remember that all the blood supply comes from the branches of the external carotid artery. So they are all very powerful and high pressure systems. So any mistake by the surgeon in not identifying a proper bleeder can result in a major bleeding. And hematoma and edema of the uvula, and sometimes the children complain of earache more than anything other problem. Then velopharyngeal insufficiency can happen for a couple of days, and some tonsillar remnants may be left out. So especially surgeons who are in their learning stage, they don't remove the entire tonsil, and then it sloughs off after that. That may be the cause for the secondary hemorrhage if they have not removed the tonsil properly, or it can sometimes regrow also, and I have seen recurrent growth to be needing of surgeries on some of the occasions. And the child has got an enlarged adenoids. This is how the faces will look. The child will always keep the mouth open. The lips are not closed. And the adenoids will be at the back. And adenoidectomy is indicated in hypertrophy causing otitis media, recurrence otitis media with CSOM. Suppurative otitis media, upper airway obstruction and obstructive sleep apnea, and recurrent rhinosinusitis. Some children also develop epistaxis because of the infection there. This is a classical case of cleft palate. So it's not a complete one, it's an incomplete cleft palate involving the soft palate and part of the hard palate. So this is a contraindication. Acute respiratory infection. During acute episodes, no child should undergo surgery, or during any poliomyelitis. Of course, thanks to the vaccination, now polio has been claimed to be eradicated. So earlier it was one of the contraindications, and any bleeding disorders or anemia, cleft palate are all contraindications for adenoidectomy. Sometimes there may be what is called a submucous cleft, which is not seen. Okay, this is whenever you see the uvula is in two pieces, bifid uvula, there may be associated cleft cleft also will be there. So sometimes the whole palate may look apparently normal, but there will be a gap here inside that will be seen like a bluish line. That is called the submucous cleft. And then adenoidectomy also is done under general anesthesia, and then it is usually combined with tonsillectomy also in cases where indicated. So you have to avoid hyperextension to prevent the cervical vertebral bodies getting damage to the ligament, which is called the Grisel syndrome. And this is the classical way the mouth is opened. You can see the Boyle-Davis gag is applied here. The mouth is opened by pulling the tongue blade, and then these circular things, this is called the Darfin's bipod. Okay, there will be a rod underneath with holes, and you have to adjust the height by putting this rod in those holes and then hooking on the end of the tongue blade to this. So this is called the Darfin's Boyle-Davis gag with a Darfin's bipod stand, how it is corrected. So this picture will tell you how to visualize the surgery. So this is the damage that can be done by hyperextension, Grisel syndrome, due to infection of the periodontoid vascular process. So it's a non-traumatic subluxation of atlantoaxial joint. That is the pathology. Then this is the technique of doing adenoidectomy. Okay, they use that curette. It's called St. Clair Thompson adenoid curette. So this will be introduced into that, and then sweep it against the bone and remove all the soft tissue there. So held like a dagger, and then downward and forward sweeping movement. Adenoids are shaved off. Actually, they are all not under vision. So blindly, with the feel of that soft tissue, you have to shave it off. A smaller size curette is used to curette the adenoids around the choana, and the larger one around the eustachian cushions. So there are different types of the tips for that. And then other techniques are suction coagulator. Just like the different techniques for adenoid tonsillectomy, you have these different techniques which you need not bother about. This is the common method which is used by everybody, which you have to know. Coming to postoperative care, again, these children are also to be kept in lateral position, and then watch for bleeding. The complications, again, all the same complications like your tonsillectomy. Now I am just going to show you a few instruments. Can you identify this instrument? Are you all there?
Cross,
Hmm?
Cross Davis. Yeah.
This is a Boyle-Davis gag. This is what we use. Now, what is the difference? What is this instrument? What is the difference between this instrument and this? This is not the entire instrument. This is only what is this called? This is the tongue blade. These are the grooves for the ratchet to fix it. You know, when they pull it out, there will be a projection which will hold into that depression. This is called the ratchets. So you can see there is no hole in this blade. This is the older type of blade where they used to do only nasal intubation, and this blade is for lifting the entire tongue, which need not accommodate the endotracheal tube. So this blade is ideal for nasal intubation cases. Whereas if you are going to do oral intubation, there should be a groove to accommodate the tube. Okay, otherwise this sort of flat tongue blade will compress the tube and cause an occlusion. So this groove is for oral intubation accommodating the tube. And one more thing, these are all various sizes of the tongue blade which can be used according to the patient's age. Now if you see this blades, there is one tube and a nipple-like thing here. Can you tell me what is it for? Any historical importance for that? Hmm? See, this is for supplemental oxygen, or in the olden days, they used to connect the entire anesthetic delivery tube to this. Okay, this will be projecting outside.
Oxygen
So they
delivery
can connect oxygen
gases.
as well as volatile anesthetic agent. Earlier days when Boyle Davis devised that, they used to do only inhalation induction. They never used to go for intravenous induction. And after the sufficient depth of anesthesia, they used to apply this gag and connect the same anesthetic delivery tube to this knob, this nipple-like thing. So that
Endopharyngeal, sir. Endopharyngeal anesthesia.
this will be going very close to the larynx. And so this whole anesthetic will be delivered to the patient because he is spontaneously breathing. He will continue to remain anesthetized. And then at the end of the surgery, they will cut off all the thing and then regain consciousness. Okay. So this is for supplementing. You can give oxygen or you can maintain anesthesia itself through this. That was the technique adopted in the olden days. And this is how the whole thing is introduced. This is the bipod, this is the Draffin's bipod, where, this rod will be introduced under the back of the patient, and these holes will be projecting from the side. So once the surgeon puts the bag, this long rod will be seated in the various holes that are available, and according to the opening and the height of the patient, it will be hooked on. This bent end will be hooked into this circle. I think ideally he has covered this, how it is being done. Can you identify this instrument which is used during tonsillectomy?
forceps.
This is called the Valsalem forceps. Okay, the same thing which the Ogicians use for holding the cervix also. Okay, so both ends you can use the same instrument. Okay, and using this instrument only they pull out the tonsil. What is this instrument?
Curate, sir. Curate.
It's a tonsil dissector, the blunt dissector. They will use it after releasing that. What is this instrument?
Snare instrument, sir.
This is called the tonsil snare. Okay. What is this instrument?
Curate, sir.
This is the adenoid curate. Okay. What are all the various instruments you see in this?
Last is towel clip, sir.
Very good. Easiest.
Curved artery.
Curved arteries,
Eighth artery, sir.
needle holder, scissors.
Sponge holding forceps.
Yeah. So all these things correctly identified. And what is this? If anybody identifies, I will get them an ice cream. This is called the knot pusher. Okay.
Oh,
So whenever the surgeon wants to tie a bleeding vessel, they will hold it with this curved artery forceps and then take a long thread, and then to tighten that they will hold it one end, and this gap they will push the whole thing into that and tie the knot. So this is called a knot pusher. Okay. I think that's all the right. So that completes the discussion on adenotonsillectomy. Any doubts, any questions, any additions? Vasanthi, anything have to be added?
So, no, so I think we've covered everything. Only thing is probably we should also tell them that if the patient has adenotonsillitis and some other procedure, we have to be careful about the airway management. I've had a patient like that, sir. That's why.
Okay,
A pediatric patient. Actually, I examined only the lung. I didn't look at his mouth and all that. So,
okay.
mouth opening, all that was not checked at all. I didn't check. So,
Okay.
just the respiratory system auscultation was perfect, and he came for some other procedure. So only when it's just a POP for a recurrent dislocation of the hip joint. So obviously it was a minor procedure, and started holding the mask, sir. And then at the end of it, the patient started having difficulty in breathing. So for no reason, it was only brain and holding the mask, nothing else. So then I did a laryngoscopy and saw it was a huge tonsils, sir. But he was posted for something else.
Okay. Yeah.
That is something I think we need to just educate them on that.
Yeah. You must be aware that it could be the cause for difficult intubation also. Difficult airway, rather.
Sir, can I add one more thing, sir?
Please.
This is not for the exams candidates. Actually, it is the recent development for knowledge sake. I'm sharing this. There are some articles published quoting that ketamine can be applied locally on the tonsillar bed after the surgery, and that gives very good pain relief, post-operative pain relief. Topical ketamine on tonsillar bed.
The infiltration of local anesthetic into the tonsillar bed, many times, many people say that it is not that much effective like other methods. And I know one surgeon who was working with me in my institution, who used to do all adult tonsil under local infiltration anesthesia in the sitting posture. He used to make the patient open the mouth, use only a tongue depressor, and then infiltrate the anterior and posterior pillar and finish off the entire dissection in 5 minutes time. And I have seen him do hundreds of cases like that in all adult tonsils. And he had a very successful career also. And but it's not at all possible in pediatric patients. So adults may cooperate and may be able to do that. And the other risk is if you do it under infiltration block like this, then depending upon the local anesthetic that you use, the reflexes may be not brisk like a normal patient. So there is a chance that the patient can have some aspiration problem also. But luckily in his hands, he has not had any complications. He used to do that regularly.
So I think in the exams, they will also ask them about the use of LMA for tonsillectomy.
Yeah,
Because,
that's why I showed that
something
picture
about
how it is.
flexible LMA.
Yeah. We
But
are
this
not
regular-
using it regularly, except one PG doing it as a thesis for in the long back. But surgeons are not very comfortable using that because you don't fix the LMA and it is likely to move, and it's got a long learning curve. Both the surgeon and the anesthetist should be competent to manage with LMA. So then only it can be done comfortably. Otherwise, it is much safer to intubate and maintain, have a patent airway. Okay. Shall we?
Can we move on to the next